Great. Thank you, Danielle, and to the National Consortium of Telehealth Resource Centers for including me in this fabulous webinar this summer. Excited to be here and share with you. And certainly Danielle knows how to find me if you all have questions at the end that need to be kind of discussed further. I'm happy to be reached out to. The key points that we're going to cover today, really looking at the clinical evidence of the use of telemedicine, but also thinking about understanding how our TeleWOW experience, which we did, started roughly a decade ago, and how we grew and developed, as all of us did during the pandemic timeframe, but also sharing some practical approaches in the implementation and the role of telemedicine to address access and equity as it pertains to pediatric obesity specifically, which is what TeleWOW was all about way back a decade ago. So we created this timeline to remind us of the evolution of telemedicine. So certainly going back way back in 1924, the virtual medical visit was predicted via the radio. And then the first radiographic image was shared via the telephone in 1948. Certainly with the internet starting to be available in 1983, we saw expansion of the use of telemedicine. And then we see the establishment of the Office of Advancement of Telehealth in 2006. For me, my first exposure to telemedicine was when I was still doing primary pediatric care in the most northern part of the state of Maine, through a small March of Dimes grant where we were able to provide genetic and pediatric neurology telemedicine visits way back then, which was super exciting. And then we started our pediatric obesity clinic at Northern Light EMMC in Bangor, Maine, and that was a comprehensive interdisciplinary team approach that was all in person. And we realized that we were caring for patients in our very rural state of Maine, and how do we really provide care to all patients? And that's when we thought about providing our TeleWOW program in 2015. Certainly all of us experienced the pandemic in 2020, where we saw the increased need for utilization of telemedicine. And now, as we think about what happens as the PHE ends or temporary flexibilities are at risk, this is the time to really start to advocate for the care and the lessons we've learned collectively by leveraging telemedicine to improve care for our patients. So when we think about telemedicine, where are we now? There's such growth of modalities, right? Many of us have had experiences with using synchronous, asynchronous, video, audio-only visits, the e-consults, remote patient monitoring, patient portal messaging for us as clinicians to better care for our patients, as well as provider-to-provider consultations, educations through e-consults and echo learning modules. We've all really experienced telemedicine in a way that helps improve care. But particularly, I think we've seen patient satisfaction, patient availability, and provider efficiencies have really improved. We need to be cognizant of the need for confidentiality and extension of those policies to provide the care. But most importantly, I think as a result of COVID and the pandemic experience, the vast expansion and uptake of telemedicine, we've seen in some reports 38 times higher utilization from the pre-pandemic timeline. And we saw that 92% of patients really did prefer to have care in their home, which was really vitally important for our care. So when we think about telehealth policy changes after the public health emergency, we see on the left that there are many permanent Medicare changes that are very important to providing care. Federally qualified health centers and rural health centers, for example, can serve as a distance site provider for their behavioral mental health. Medicare patients can have that care in their home, as we just shared. Many of them prefer that for lots of different reasons. The no geographic restriction for the originating site is so important for both behavioral and mental health, but also non-behavioral health medical care. And that's what we see on the temporary side, right? Many of us have been advocating, I know I've worked with Danielle and many others, to ensure that we continue to have care for patients. This is really important when we think about pediatric obesity care in rural settings where the no geographic restrictions for originating site is really important. Some non-behavioral mental health services can be delivered using audio-only communication platforms, particularly for patients who maybe have limitations in terms of broadband. And then in-person visits within the 6 months of an initial behavioral health or mental health telehealth visit and end thereafter is still not being required. And then telehealth services can be provided by all eligible Medicare providers. So this is really the time to continue to advocate for patients' care. And Danielle put together this fabulous slide of resources that I think all of us will be turning to during this time. I know I'm looking at the CCHP, Understanding Telehealth Policy, in terms of permanent and proposed extensions of state telehealth rules and regulations. So we want to continue to work with our healthcare teams and systems wherever we're employed and working to be sure that we're following those, but still advocating for the best access for care. Particularly Connect for Health Act of 2025, which removes longstanding barriers to telehealth and promotes program integrity, as well as the Telehealth Response for E-Prescribing Addiction Therapy Services Act, which would permanently waive in-person requirement for prescribing controlled substances. And even for pediatric obesity care, this impacts the care that I can give for our patients, as we do sometimes utilize medications that would require that. And there was a strong pushback by many of us who really rely on the ability to provide care via telemedicine. So thinking about advantages of telemedicine in general, right? Many of us experienced COVID and we've utilized telemedicine. We know this can improve access. And when we think about increasing care and access where and when patients need it is very patient-centric, and many of our patients have shared that going backwards is just not possible to contemplate in their minds. We know it improves capacity of us as providers, and if we can do that, we can reduce disparities for those patients who are living rurally or in less serviced areas. We've seen and experienced high patient and provider satisfaction. In one of the papers here, we saw 95 to 100% were satisfied with their telehealth visit compared to an in-person visit, and almost 80% reported satisfaction with their most recent telehealth visit. In terms of cost savings, we see value for patients and healthcare systems where we can document less ER visits, shorten hospital stays, as well as a really interesting paper that I came across that showed in California, a 2-year project estimated at 53 million miles of safe travel for patients by using telemedicine over that 2-year period. So we can think about it in terms of impact on the environment as well as savings. And ultimately, our goal as clinicians is to improve patient outcomes. And we can see here in this data that physicians shared they had experienced improved clinical outcomes, 88%, care coordination, 83%, increased patient adherence, and increased patient safety. We know remote monitoring can decrease ER visits and reduce hospital stay lengths, as well as patient engagement and provider access to patients. So ultimately, as we provide care holistically, this really does illustrate the utility of telemedicine. Expanding telehealth in adolescent care, moving beyond the COVID pandemic, was a very interesting paper by North et al. That was published in Pediatrics a few years ago. And I think looking back at this paper, it illustrated that it was essential to consider the full array of virtual care modalities to enhance access to care for adolescents, and I would say all pediatric patients as well. In a survey that they did in 2016, only 15% of pediatricians had reported using telemedicine in the last month. And certainly as a result of more expansion, particularly even pre-COVID, a lot of the school-based centers were starting to utilize telemedicine, and we saw that uptick of almost 271%. And then in 2019, a study of use of in-home telehealth devices that included a stethoscope in children and adolescents with medical complexity showed lower ICU admissions in the intervention group and cost savings for the patient over that 4-month study. However, in this paper, he documents, despite emerging evidence of the benefits of telemedicine before the pandemic, there were still concerns regarding the lack of evidence to support its use that had persisted. So for those of us who were using telemedicine before the pandemic, we kind of got it. But we really illustrate the need to grow resources to better inform our providers and stakeholders of the utility of telehealth. One of those partners was the American Academy of Pediatrics section on telehealth care, which has consolidated multiple national evaluation framework into 4 domains, which I think are really interesting, including health outcomes, health delivery for quality and cost, experience, and program implementation as key performance indicators. In this paper, he did highlight there are risks, right? There are chances to exacerbate healthcare inequities, and we need to be mindful of that. We need to ensure telehealth products are developed with a focus on maintaining adolescent confidentiality as one of the major key points. But ultimately, the benefits for telehealth may allow ongoing adaptive conversation focused for adolescent wellness. We know in the data that oftentimes adolescents tend to drop off with their routine healthcare, but leveraging telemedicine can improve that. Also thinking about geographic capacity limits for those subspecialty pediatric care for adolescents, including adolescent medicine. And what they found was virtual visits have tremendous potential to decrease those geographic barriers. And I would say from the experience pre to post-COVID, even those of us who are living rurally and practicing rurally, we experienced that. But for our colleagues who are working in inner cities, having the ability to use telemedicine was really important for their patients as well. Just kind of thinking about traveling through the city, parking, getting into their visits, that could be 4 hours, even though it may not be very distance from their home to the clinic. So not only for rural, but also even urban settings. And telehealth has the potential to transform how adolescents engage with healthcare systems. Ultimately, it's the responsibility of all of us as clinicians and healthcare systems to adapt practice styles to meet the needs of our adolescents and adhere to the expected standards of high quality, confidential, and comprehensive care models. And I would say this applies to our pediatric obesity care as well, which we'll share. In terms of barriers for telemedicine, we know that we need to be aware of the potential to worsen socioeconomic disparity. We know that not all communities have equal access to broadband, and so certainly lots of funding and attention has been given to that, as well as to think about technology and devices being available for patients. We need to think about the maintenance of telehealth policies to address restrictions and payment parity, certainly thinking beyond the short-term financial fee-for-service, but really redefining and expanding that value definition. And then thinking about prior geographic and provider-specific limitations that we need to continue to attend to. COVID really highlighted the need for stronger infrastructure, education, and workflows for the staff to support telemedicine. Many of us who were doing this a decade ago, we were trying to do it all and manage it on our own. But certainly when this came to be a vitally needed tool during COVID, we really highlighted the need to support this kind of care delivery. And ongoing payment uncertainty has limited the utilization or expansion of telemedicine, so continue to advocate for that. There's a great paper that looked at drivers, barrier drivers, including competency drivers, thinking about participant engagement barriers, really talked a lot about caring for your community and engaging your community that you're going to be providing the care to really inform how you develop your telemedicine programs is really important to help alleviate any potential barriers. Thinking about staff training barriers, inadequate program supervision and management, as well as operational drivers such as inadequate decision, administrative clinical support, system level and leadership barriers that we need to engage. So I'm shifting a little bit to thinking about how does this pertain to obesity care in pediatrics, and our program that we started in 2009 was really an all in-person care model across our multidisciplinary team to really address the complexity of the pediatric obesity patient. So we talk about this in our obesity medicine algorithm, where we define pediatric obesity as a disease that is complex and chronic and requires a lifelong management of a multimodal team. So we needed to have medical, dietary, nursing, psychology, all as a group. And we were focused on providing the best standard of care, which is high intensity, 26 contact hours across this team of intensive lifestyle therapy, along with use of anti-obesity medications or metabolic bariatric surgery, depending on what our patient needed. And we knew we were living in a rural state. How do we provide that level of care to our patients who are really far away? And we needed to solve that problem in order to improve our overall management goals, which was to develop healthy lifestyles for patients into adulthood, improve their current health and quality of life, achieve healthier body composition, prevent and treat current consequences of obesity, and ultimately improve how patients feel about themselves going forward. And this really requires us thinking about obesity as a chronic disease. There's biology there. And then also we need to address all of the obesogenic environmental factors that are overlaid on this biology predisposition for our patients. And really having that conversation and being able to utilize the full team can help remove some of those barriers for patients. And if we address obesity as it results from pathophysiological dysregulation and providing treatment, hopefully we can improve care for patients. And this goes a long way in terms of acknowledging that the complex etiology of obesity, explaining it in that way helps to do away with the myth that patients who have obesity is a result of poor choices, lack of discipline, or willpower. We know that that perspective only increases stereotype and stigma for patients living with obesity. And if we come at this from a complete complex model, looking at the interaction of the environment, the genetics, biology, as well as societal, psychological, and behavioral factors, we can reduce bias and stigma. It improves understanding of obesity as a complex disease. And for our patients, we can help reduce blame and increase self-efficacy for behavior change and accessing care. And if we're going to ask our patients to access care, we need to make ourselves available and utilizing all the tools in the toolbox, including telemedicine. As we know, obesity, as it does for adults, it impacts all body systems for our pediatric patients as well. And so we know we need to be doing a very comprehensive job of caring for our patients in this moment. Because we know what happens when we do not treat childhood obesity. We see from the data, there's increased precedence of prediabetes in our patients, up to 2.6-fold higher for patients who have obesity for prediabetes, 60% higher risk of obstructive sleep apnea. We see higher liver disease, including 38% for children with obesity. In terms of cardiovascular disease, 70% of children from age 5 to 17 with overweight or obesity had at least one cardiometabolic risk factor. In our own pediatric WOW clinic, our data from a 2017 of almost 400 patients from age 3 to 18, 95% of them had at least one cardiometabolic risk factor at the time of enrollment into our clinic. We also need to be cognizant of the psychological distress that is greater for children with obesity related to teasing and bullying and the bias that exists. And ultimately, we know there's poor quality of life for patients, even in our youngest of patients. So we really want to be able to provide the comprehensive care when and where patients need it the most. So we saw the significance of telehealth during COVID, particularly for this cohort of patients living with obesity, as we saw increased poor outcomes for those with obesity if they had the infection of COVID. We also saw a negative impact on any of our goals that we're working on, as many patients experienced that social isolation and school closures. Many of them required school meals, for example, as part of their dietary work with our dietitians. We saw increased screen time for all of us as patients were doing all of their learning online. And more importantly, I think we saw some relationship to higher obesity risk during COVID, as we understand the pathophysiology of exposure to chronic stress has that negative impact on the obesity physiology, that we're not surprised that we saw worsening of obesity for many children and adolescents during this timeline. But we also saw that patients who were able to still access obesity care via telemedicine, either to initiate or continue care across that team, all of us being able to continue to interact and build on those goals, they did better over time. And so we really need to continue to think about that going forward. So going back to our evolution of telemedicine for our TeleWOW program, we started, as I said, about a decade ago when we provided this care. And our main goal was to provide the same level of care for our in-person as our patients receiving care virtually. COVID certainly has pushed many of us as healthcare providers outside of our comfort zone to use digital solutions for our medical care. And incorporating telemedicine into our practice is now the new normal. And it has allowed us, if we think about a silver lining from COVID, it maybe allows us to reimagine our medical care outside of a physical office building as a means to improving patient care. And the evidence for pediatric obesity really shows that telemedicine can enhance patient outcomes, benefits that improved compliance rate and reduced attrition. Prior to this, the traditional in-person pediatric weight management comprehensive team often saw 40 to 70% attrition. If we can reduce that, we have more access to our patients and can improve that care. We know we can have increased access to rural settings and decrease operational costs and deliver efficient pediatric obesity care. What we learned from others, particularly Whitley et al., talks about perhaps a sweet spot of hybrid version of telemedicine, whether it's in person, 100% virtual. Our goal is to really meet our patients where they are. Some of my patients have said, I really like all telemedicine. Some families are more comfortable with all in person. Many are flexible and like to be able to use both. So really being able to adapt this to be specific to each of your patient's needs. And obviously, ongoingly, we need to think about socioeconomic disparity requires policies to help provide these tools to all patients equitably. A number of years ago, I worked on a paper with Dr. Shrivastava looking at barriers to pediatric obesity care specifically. And I think about access to medications, bias and stigma that we touched upon, attitudes and perceptions and knowledge about obesity in general, the need for education. Certainly using telemedicine has provided many, many opportunities to provide ongoing education for our colleagues and medical students, eco-learning tools, et cetera. We know we need to think about ongoing health policy issues as well, and insurance coverage and bundling for payments for providing this care. But specifically, when we started our TeleWOW, we were thinking, how do we leverage our tertiary pediatric obesity medical team, providing that care to be given to patients who are living rurally? And so we know we can make a big impact. When we think about the most recent data from the American Board of Obesity Medicine in 2025, compared to our first year of 2012 of obesity medicine certification, nearly 10,000 providers are now obesity specialists. And we see that almost 10% of us are pediatric obesity specialists, and some are family practice or internal med peds combination with doing some pediatric care, about 38%. What we know from this data is that most of our obesity specialists tend to be located in larger academic centers. And we also know that patients who live rurally have higher risk for obesity. And so our TeleWOW really bringing our comprehensive medical team of obesity experts to the patient living rurally was vitally important. And if we talk about this approach in terms of the RE-AIM framework, we can look at utilizing telemedicine to improving pediatric obesity in terms of reach, effectiveness, adoption, implementation, and maintenance. So advantages of telemedicine specifically for children with obesity, we know we can increase our reach. We can decrease attrition with less no-shows, less cancellations, and certainly, most importantly, I think what I've experienced over the last decade is the ability to include more caregivers involved in that patient's care. So perhaps it's a BHP worker, a one-on-one aide from school, a social worker from school. They can be joining our visits and participating in that improved education and shared goal setting for our families. We also experienced the invitation into home to inform care. So we had unique insights from meeting families in their home environment, being able to share what's going on with them in a way that was perhaps different that you may not appreciate in an in-person, typical come to the office visit. We know we can have additional caregivers to support patient care during the visits. I know our dietitian during their medical visits, patients was oftentimes bringing a label to read together. They could share what they had on their menu for the week in real time. And that was very, very important and helpful to our families. In terms of high patient and family satisfaction, what we saw in our experience was less anxiety and stress for patients with special healthcare needs, such as autism or social anxiety. I remember one mother telling me that if she had to bring her kiddo to an in-person visit, it would take days to prepare, versus when she could come into the home, the patient could be comfortable, have other providers there to help her during those visits. It was a much more productive visit for all of us. For those who've experienced prior weight bias and stigma in the healthcare setting, which we know for patients with obesity, including children and adolescents, they tend to avoid medical care. But this is our opportunity to rebuild that trust with their providers in a much more comfortable modality that many of our pediatric patients are most comfortable with. And we could see that happening over time. Perhaps the first visit with one of our adolescents, they're half on the screen, not making eye contact. But over time, as we rebuild trust, I could see them joining more happily and engaged and interactive, and maybe being on the screen completely. Some patients saying, you know, I never would have thought I'd come see you in person, but now I'm kind of comfortable doing that. So this is such an important aspect of providing care to our youngest of patients. In terms of expanded value assessment metrics, I think better equity, improved access, outcomes, and satisfactions of patients and providers is really important, as well as looking at cost effectiveness and climate impact that we talked about a little bit earlier. And then remembering to leverage the medical home and the team. Certainly in a paper by O'Malley et al., they talk about access to a shared EMR for data and communication can improve safety and efficacy for our patients. And then if that's not possible, thinking about all of our other colleagues that are involved in our patients' care, whether it's reaching out to the PCP, a school nurse, encouraging families to utilize the portal system to share those metrics with us can be very effective and should not be a barrier to care. What are future challenges of telemedicine for children with obesity? And we did have this brand new section of telemedicine or pediatric obesity algorithm for the OMA. And we talk about many of these issues, specifically about childhood obesity and as it pertains to telemedicine. So when we think about policy and coverage of care, we really want to focus on equity. That includes obviously the congressional inertia regarding the Treat and Reduce Obesity Act, which affects all patients of all ages with the disease of obesity in terms of access to appropriate care. But we also need to address the telehealth policies and making sure that we can continue with our current permanent and addressing those temporary flexibilities that many of us are going to rely on in order to continue to provide care to our patients. There was a great paper by Bomberg et al. That looked at childhood obesity as a public health emergency. So really being able to use all tools, everything on the table to provide care. And if I tie that in with our telemedicine perspective, Fang et al. Really talked about digital equity in terms of using telemedicine really starting to be viewed appropriately so as standard of care. And then therefore access to that to be viewed as a human right. And certainly COVID and the invaluable use of telemedicine, it's the time to leverage that significant lessons learned that we've all had collectively and move forward. In terms of concerns regarding accuracy of physical exam, vital signs, and medication management, I'll talk a little bit of that in our future slides, but I think I get that question a lot from our pediatric obesity colleagues. But again, remembering to access your shared EMR, consider all of your colleagues, and then access to multiple telehealth modalities, including remote patient monitoring, can improve those aspects of care. And equitable for vulnerable populations. For those pediatric patients living rurally, we know there's higher risk. For those who are underserved, special needs, telemedicine is vital to access telemedicine obesity specialty. So we need to continue to focus on those effective outcomes. This past spring, myself and a colleague, Dr. Suzanne Kuda from Texas, shared looking at comparison of obesity models for adults versus pediatrics. And we see a lot of overlay here, that most of the care, as I said, tends to be in academic, larger centers, hospital-based. There are some private practices for pediatrics and adults, although more adult. And most of those are offering some telehealth visits as part of their overall program. In terms of direct to pay and non-traditional medical spas, that tends to still be heavily on the adult side, although we are seeing a growth in the telehealth obesity platforms. My new role at KnownWell will be to expand the use of telemedicine for providing virtual care, as well as in-person hybrid care for pediatric and adolescent patients nationwide. So going back a decade, insights from our TeleWOW program pre-COVID, what did that look like and how have we evolved? So our initial visit at the time, the originating site had to be a medical center. So we partnered with our local pediatric practice up in the most northern part of the state of Maine. So we went up and saw our patients in person. Our follow-up visits the patients were seen in that visit while we connected via telemedicine. And then every quarter we would go up to see new patients. We certainly were able to publish and talk about our initial successes, which certainly we know we increased access to care, particularly if we're thinking about meeting those U.S. Preventive Service Task Force guidelines of 26 contact hours. We had significant positive collaboration with the primary care practice, all of their staff, as well as other community partners. We were able to work with a local college to provide in-person physical activity with their personal trainers, and patients and staff and collaborators had significant positive feedback. There were challenges, obviously, at the time in terms of credentialing processes and contracts. We need to be mindful of training to have cross coverage of the staff at the originating site and anticipating that, but also being respectful that our patients were being seen in their space. And so we had to be flexible if there were schedule changes for any of their providers as well. So at that time, pre-COVID, we had about 10% of our pediatric obesity care was via telemedicine. Many of us had to completely pivot 100% to telemedicine during COVID, and we were excited to be able to share with some of our colleagues who had never done any telemedicine to be supportive of them during that transition time. Post-COVID, at the time of our clinic there, we had about 60% of our care was via telemedicine, and for our dietitian and our psychologist remained 100% telemedicine. So in terms of future of telemedicine post-COVID, the successes, we know we can improve access to care for patients. We can reduce attrition, and obviously being mindful of challenges, right? So we don't want to worsen socioeconomic disparities, and we need to continue to focus on policies and fee structures as the expectation of telemedicine as a standard of care and improving efficacy of our patients' care. So what did this look like in terms of conversations with our patients who had obesity during our telemedicine visits? And the major key steps and points that we left with were really thinking about it from the very beginning. How are we booking our appointments? We understand that sometimes families are joining from different locations, as are our team. So how do we do that? And remembering the safety and comfort of their homes, asking who else is present if they're outside of your screen, to be really cognizant about confidentiality and care. How do we monitor for vital signs, right? We talked about that. Use of remote patient monitoring, collaborating with our healthcare providers, our school nurses, and using the patient portal to share that information so we can continue to provide accurate care. For our clinic, we had a lot of hands-on learning in the in-person visits, so we really needed to adapt and develop educational materials that could be shared during a telemedicine visit. So we developed lots of PowerPoints and shared pre-recorded materials, even how to use devices if patients had a new medication that was an injectable medication, for example. We were able to provide nurse visits either in person or via telemedicine to successfully train our patients and make sure that they feel comfortable with their new medication. We were able to think about our visit the same way we do in person. We were able to join with the patient, talk about their successes, their medications, their challenges, and work together to develop a treatment plan with the patient and the family. And we were also be able to integrate our goals across our disciplinary team, oftentimes having nice warm handoffs to our other team members, whether it's the dietitian or our psychologist in our nursing care. We saw the involvement of our interdisciplinary team across those dietary behavioral health consults really augmented the flexibility to our patients and our families. We experienced enhanced connectivity with the availability of various locations, and saving on the cost and travel of time, snow days, sick days, all of those sorts of pieces that helped improve our access and decrease no-shows and attrition. Most importantly, we saw increased openness and the unique opportunity to share in the patient's home with them. Many times my patients would bring their pets on, and that was always fun too. So better engagement with our patients, specifically those who had special needs. We certainly heard that and continue to hear that from many of our families, and ultimately improved efficiency among the interdisciplinary team. And this was our first paper. We had a poster presentation on our first pilot of our TeleWOW program way back then in 2017. And we really ultimately showed that we could certainly provide moderate to high intensity care for patients with pediatric obesity using telemedicine in a very close to home for our patients. In terms of sustainability of the hybrid model, in terms of insurance and policy, we know we need to continue to develop healthcare policies to incorporate telemedicine. We need parity in terms of insurance coverage for telehealth and hybrid. And we need to do this across the 6 Ps for patients and parents, providers, policymakers, payers, and the public. And if we can do that, we can help to reduce bias and stigma and increase access to ethical care for obesity. So summary of our gaps, we know we want to make sure that any limited access to pediatric management care for most vulnerable patients, those living rurally or socially economically disadvantaged communities, consider risks of diagnostic errors in terms of safety, equitable access to all care, and improving the access in terms of research to include those most vulnerable patients, and looking at policy and funding ongoingly. We talked a little bit about these bridging the gap, and we're providing seamless obesity care across the lifespan with some of our colleagues at OMA this past spring. And particularly, we showed the need for the core disciplines in this integrated multidisciplinary team that you see there, but also thinking about many of us are using those integrated obesity clinic structure elements. And we see here front and center, telemedicine and hybrid was vitally important for all of us who were presenting. And we shared the creative use of telemedicine to increase full-time use of our providers in terms of access as well, really accessing those underserved areas, saves time, travel, warm handoffs, and all those other advantages we talked about. And we share this again in our obesity medicine pediatric algorithm to really looking at those advantages for ongoing care for patients with obesity. Additionally, a colleague, Dr. Janie Pratt and Dr. Hertz et al. Really published their experience with the effectiveness of telehealth implementation for their adolescent metabolic and bariatric surgery program in California. They too experienced a greater attendance for their patients versus their in-person, less cancellation, and ultimately the evidence that telehealth can be implemented successfully for their adolescent metabolic bariatric surgical program across the board for them. So summary of opportunities, access, 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 right? So addressing healthcare equity by building telemedicine policy, ensuring safety. We can do that by leveraging the medical home and workflows that are effective and looking at medications for reconciliation and vital signs. And so we can see that, and of course, addressing disparities that needs maintenance of permanent changes and support at risk PHE extensions. We talk more about this in greater detail in this resource here that I stick here if you are interested in learning more about pediatric obesity in general, but also how we use telemedicine. And then, of course, our collaborations and supports from the Interstate Medical License Compact for telemedicine, as well as HRSA's telehealth resource centers that are regional, that I have so much appreciated their support over these years, and I continue to learn from them all the time. So last thoughts from our TeleWOW team and families. Families really allowed all of us as healthcare providers into their lives, and now as a result of COVID and telemedicine, into their homes. And as healthcare providers, our goal, we strive, is to provide the best, highest quality of care for obesity, regardless of how we're using it, whether it's in-person, hybrid, or telemedicine, and regardless of where patients live. Telemedicine enhances obesity care by providing an additional tool to stay connected to their patients and families through their successes and, more importantly, to their setbacks. If we reimagine telemedicine post-pandemic, it is the new reality. We cannot go backwards. So we need to continue to advocate so that we can continue to care for our patients, and seeing the response on their face when we connect, whether it's in person or virtually, is the ultimate privilege and the reward of the work that we do. So thank you so much, and I look forward to your thoughts and questions.